BBC Sounds. Music, radio, podcasts.
Hello, I'm James Gallagher and welcome to the Inside Health podcast. I've been feeling a bit under the weather recently. I might actually have my first sore throat since before the pandemic started. So I have been feeling the pressure when it comes to my regular lateral flows. They're all coming back negative at the moment, so I'm still here making the programme. But I have noticed a mountain of plastic waste starting to build up in my bathroom bin. I've got some of the lateral flows with me here, the unused ones, obviously. And it's not hard to see why. The swabs, they come in their own bit of plastic packaging. Then you've got the test itself. That comes in like a combination of foil and plastic packaging. And then there's all the vials that have got the little drops in as well. There's just loads of it. And that's just me doing my tests at home. So in this Inside Health, we're going to take a look at the NHS's waste problem, how the pandemic has made it worse, and what the solutions for it could be. And I don't know if you remember that shortage of blood vials in the NHS. Whatever happened to that? We'll find out and ask the provocative question, were we just testing too much anyway? But first, our cardiologist, Dr. Rohin Francis, has been assessing the mountain of plastic waste in his hospital.
I'm in the cardiac catheter lab, what cardiologists kind of call our operating theatre, and we're waiting for an emergency case to come in, our fifth one of the day. One of the nurses is getting all the equipment we'll be using ready, and almost all of it is single-use plastic. Each plastic syringe, catheter, clip, drape, wire, stent, gloves, and so on, all come individually wrapped in plastic. The other day, we unpacked a prosthetic heart valve, and I could scarcely believe how much plastic it involved, like a game of pass the parcel with something like 4 layers of packaging of progressively smaller containers until the tiny item was found inside. Now, don't get me wrong, if you had to give a pass to any sector when it comes to pollution, it would be healthcare, but it is my industry, so even pre-pandemic, I wondered about how much plastic waste a hospital gets through every day. And then COVID happened, and everything changed, as the whole world became aware of what the 3 letters PPE stood for. Understandably, we took all precautions we could and donned multiple layers of PPE, masks, visors, goggles, gowns, aprons, gloves, overshoes, and of course, all plastic. While this was entirely new for most parts of the hospital, some of us had experienced a milder pre-pandemic version in wards like intensive care. I dug something out that I wrote in 2019 about the almost ritualistic way all members of a ward round, which could be 10 of us, don PPE, hover in the vicinity of a patient, only one might actually examine them, only to then remove everything, essentially unused, a few minutes later and start all over again. My question back then was whether the plastic pinnies on ward rounds, while apparently sensible, were evidence-based. Spoiler, they aren't. I find most people are quite rational. For example, for years we would do things like minimise the number of people entering the room of a patient with a resistant infection, and now we do the same, but to avoid the overuse of PPE. And this makes sense, but it also means fewer learning opportunities for student and junior nurses and doctors. Not long ago, hospitals would reuse surgical drapes or instruments by sterilising them on site, but many of those items are now plastic. Chatting to some of the more senior theatre staff, in most cases that's been a move for the better, but it's not universal. One of the domestic services managers I talked to was worried about how little of the waste is recycled. Even if you feel the environmental cost shouldn't be an NHS priority, there's another compelling reason to reassess how much plastic we use, the monetary cost. Many in the NHS had started taking big strides to reduce waste in their respective organisations and saved a lot of money in the process, but these efforts were derailed when the pandemic hit. Since then, trusts have spent unprecedented amounts on PPE, and that's fine. But we shouldn't be doing things just because they feel right. We should have robust evidence by now on what PPE is required. NHS England have offered us guidance, but it's broadly been left up to trusts to procure what they can and try their best to protect patients, staff and visitors. It's a task matched in size only by the bewildering pile of blue and white I see every day as I leave the hospital and walk past a huge bin labelled masks only.
Dr. Rohin Francis there. And it's not just cardiologists noticing the build-up of single-use PPE. It is everywhere.
I'm Alexis Percival, the Environmental and Sustainability Manager at Yorkshire Ambulance Service.
Welcome to Inside Health, Alexis.
Thank you.
So, what was it that got you so knocked about face masks?
Well, during the pandemic, my procurement lead detailed that we'd got through 1.3 million face masks in the first 3 months. In the previous year, we'd used 20,000.
That's quite the increase.
And that we're just one trust. And we were just consuming so much that waste was a real problem all the way through. So across the whole of the NHS, during the whole of this pandemic, we have used 2.4 billion face masks.
Wow.
It's an astronomical problem that we're having to deal with.
So when you are an environmental and sustainability manager and you see that amount of waste, how are you feeling?
It was horrendous. I mean, it was absolutely disgusting, the amount that was being generated. There was bins overflowing, general waste locations just absolutely brimming with the amount of waste, to the extent that some hospitals in London, the Environment Agency were threatening to shut them down because there literally was not enough waste collections around the whole of the UK to accommodate the amount of waste that was being generated. And also, it wasn't just face masks. We were also looking at gowns, aprons. The plastic that we were consuming was just astounding.
We'll hear Alexis's solution for face masks in a moment. But first, let's zoom out a bit. Let's look at the big picture. Because as well as the actual plastic causing a problem, it's all coming with a hefty carbon footprint too. How big, I hear you ask? Well, Dr. Chantal Rezan, who's a research fellow at the University Hospital Sussex NHS Trust, has been crunching the numbers. Chantal, welcome.
It's an absolute pleasure to be here today.
When we look at the NHS as a whole, because the NHS is one of the biggest employers in this country, how big an impact is the organisation having on climate change?
So it's really quite surprising. Our contribution to greenhouse gases in the UK is around 24.9 million tonnes. To put it in perspective of all of our...
I have no idea if that's big or small.
It's around 4% of all of our greenhouse gases. And that's a really big problem because we know that climate change is the greatest threat to human health. And so it's really paradoxical that the provision of healthcare itself is actually contributing to this problem, and in quite a big way.
There are some really big targets, though. The NHS has grand ambitions for being greener.
Yeah, we're really world leading, in fact. And so last year, the Green NHS was formed and set out a really ambitious strategy to actually meet net zero by 2040. That's all of the emissions that are within our own control. And we're actually taking responsibility beyond that to all of those emissions upstream in the healthcare supply chain. We're aiming to meet net zero by 2045 for the whole of the NHS carbon footprint.
So we've got the NHS running at normal, and then we had the pandemic. Did that make things worse?
So I had been doing my PhD looking at ways to reduce the environmental impact of surgery, but then the pandemic came along and I saw absolutely colossal volumes of PPE being used in both the healthcare context and then, of course, within
all
our
of us in
own
day-to-day life, yeah.
Absolutely. And I was really concerned about this, as I'm sure many of your listeners will be. And we know that the majority of our PPE that we're using, firstly, it's single use, but it's also made of plastics or petroleum-derived products.
Not only is it plastic pollution that then needs to be disposed of, but also there is a carbon cost in all of the manufacturing of all that kit that's only used once.
Yeah, and a lot of the issues are upstream, so it's in the raw material extraction, and then there are issues as well in that we're working in a globalised healthcare supply chain and we get a lot from overseas. That's particularly problematic when it comes over by air freight and the onward waste disposal at the end of its life as well.
I've got Chantal's study in front of me here, and it looked at the carbon cost of all the PPE used across health and social care in the first 6 months of the pandemic, and it is just based in England. But here's a couple of numbers I picked out. Around 3 billion items of PPE used in those 6 months, and if you try to do the conversion into carbon emissions, it comes out as the equivalent of 244 return flights London to New York and back every day for 6 months. So I asked her, well, what are the worst PPE offenders?
The largest contribution was from our gloves, and this was then followed by aprons and face shields and by our Type 2R face masks. And those are the masks that you'll use when you enter a hospital as a patient. You're then given one of these masks also. We could then model a number of strategies to actually mitigate that impact. And we found that by a combination of domestic manufacture, as well as rationalising and reducing our glove use, and then using reusable alternatives and recycling, it was possible to actually mitigate that carbon footprint by around 75%.
75%, that is a lot. We're going to hear more from Chantal later in the programme. But first, I want you to meet Alexis Percival in full, because she's one of the people that has decided to actually do something about the plastic mountain. And she told me about her reusable face mask. So we're talking about those bluey, whitey kind of face masks that if you go to hospital, you get handed them as you walk through the door. What are they actually made of?
They're made out of polypropylene, the plastic that we use for food packaging and various other things. But they're a medical grade one, so they have a particular layer on top. So as a plastic, somebody coughs and splutters in your face, you don't inhale that.
Yeah. And if you look on the box of face masks, is there a little recycling logo on there?
Well, you can recycle them, but because they're clinical waste, they are generally incinerated or buried in deep landfill.
How do you go about making a reusable face mask?
Essentially, it's exactly the same standard as a normal face mask that we'd all go and buy as a reusable, washable one. But because it's a clinical grade one, it needs to be capable of being washed above 60 degrees. And also we needed to make sure that everything was compliant within the hospitals, the infection prevention control systems were in place. But also they needed to be tested in various labs to ensure that they had the correct accreditation as well.
And you also have to go through that thing that, like, you see for lots of other things. This is suitable for up to 1,000 washers or something like that to actually work out how long they were still safe to use for.
Yeah, so most of them were washed to between 40 and 50 washes.
And how's the reusable mask gone down where you've been piloting it? Because I can imagine some resistance from people that kind of like have a lot of faith in those disposable ones.
To be honest, a lot of healthcare professionals are sick to death of wearing face masks. Essentially, very few face masks fit small people with long gaps between their ears and their mouth. And also, it doesn't really fit women very well. So a lot of healthcare professionals wanted an alternative that was a bit more comfortable, a bit more personalised, and something that fitted.
You said more personalised. Are you talking about the mysterious Sheffield head?
Well, essentially, the Sheffield head is an imaginary man, 6 foot tall, strong-jawed chap that basically every single face mask across the whole of the world is based on.
So instead of the Sheffield head, what have you based yours on? The Wakefield woman?
We've basically created 6 or 7 different face mask shapes. So we trialled the traditional blue face mask shape, some that were around the back of the head, some that went over your ears, some that were snoods that you pulled up. Snoods worked well for them in the call centres, but those that have turbans or those that don't like things over the back of their ears, the ones that go around the back of the heads worked. So there is no one size fits all.
I was thinking, Alexis, if you can offer me the promise of my glasses not steaming up when I wear one, I'm going to ask you to send me one in the post. So, Alexis, how did you then go on to find out if these are good enough to use day to day?
So we started with 8 trusts, GP surgeries, hospitals, and we then expanded it out. And basically we had 63 different organisations around the whole of the UK engaged in this.
And are people taking to them?
Absolutely. There's been a mass uptake in a variety of different hospitals across the UK. There's more and more people that are contacting me on a daily basis saying, please, where can I get these from?
And how big an impact on climate are they having? Because I can see that you're making the saving if you're using fewer of them, but you're also introducing new steps because you've got to do all that laundry as well.
We did a full life cycle analysis as part of this project. And to ship a single-use face mask that could possibly be using modern slavery from the Far East halfway across the world to get stuck on somebody's face for a couple of hours and then thrown in the bin, that full carbon footprint is around 1.19 kilos per face mask. If you take the equivalent as a single use for a reusable, it's 0.19, because the reusables can be manufactured within the UK, but also at the end of its life, it can be remanufactured back into something else.
How do you even keep track of how many times it's been washed? Because you said like it caps out at about 50 before you can't use them anymore.
One of the things is having a grid, tick box, to say you've used it, washed it, a chip that can monitor it through the system. That becomes a bit more expensive. Or the alternative is having either a date stamp or a colour stamp, and you take them out of circulation at the end of that time period. The same thing's been adopted with reusable gowns and reusable aprons within the hospital healthcare system as well.
Chantal, you're still with me in the studio. I think a lot of people at home, but probably also within the health service, will be thinking that there's an infection risk if you're reusing items, because there's a reason why so many things are single use. You wear them for one patient and then they go in the bin.
So we've had an absolutely exponential rise in our reliance on single-use healthcare items, and a lot of these are then plastic. And a lot of that has arisen from some of those historical concerns that we had based on quite outdated sterilisation processes. But here in the UK, we now have the highest standards globally to decontaminate our reusable items. And so really there's not the concern there in terms of the infection risk from the things that come out of either our linen laundering or from our sterile services departments. And I think what people often forget is that there's no pristine source that we get our single-use items from, and actually they themselves have got to undergo a sterilisation process as well.
Is there a culture shift that's needed within the NHS, though? Because you go into a clinic room, there's the giant box with all the different sizes of gloves and fresh face masks going on. I don't see that kind of renewable, reuse kind of focus.
Yeah, absolutely. And I think part of the issue are the myths that we're fed by the single-use manufacturers. Often we opt for single use based on a theoretical infection risk, but really we do need to be demanding that this is now founded on the evidence. A good example would be our single use gloves. We know that the WHO advised using hand washing and using soap or hand sanitizer that's got alcohol at 60%, and actually that is effective at preventing the spread of COVID-19.
I can tell you think this is incredibly important. What is the mood like when you talk to other people in the NHS?
I think there's been a real change, in fact, in this last 18 months. And I think now people are starting to see that relevance in their clinical practice, and they're hungry to find out, well, actually, what can I do and how can I make a difference?
What do you think some of the easy wins are? What's the low-hanging fruit in terms of making the NHS greener?
It's a really tricky question, but we need the engagement of each and every healthcare professional. That might be, for example, opting for a reusable face mask, or it might be opting for a reusable gown at the start of an operation. And it might be making sure that we're not opening single-use items just in case, as we often see.
There's the big mantra in everything climate-y: reduce, reuse, recycle. And so Alexa's thing is very much in the reuse side of things. What are the big reduce ideas within the NHS?
So really this applies across the board, that we need to be making reductions wherever possible, and when a given product or a given intervention isn't actually contributing to the health of that individual. And a really poignant example of that is actually with the overuse of some of our blood testing. And we know from the Carter report back in 2008, around 25% of our blood tests were in fact unnecessary. We know that an individual blood test has a carbon impact of the equivalent of driving somewhere between 3 metres and 0.8 kilometres, which doesn't sound very much, but when you take into account the millions of blood tests that we do, it really adds up.
And it's a big journey, though, isn't it? Because you think for a patient, the blood test is like a 10-second thing and it's kind of done. But the journey of that vial and all the way to getting it processed and getting the results is a long one.
There's so many underlying processes. If you think about the patient when they leave their house, they've had to arrange childcare perhaps and time off of work. They're then travelling to the hospital. Then they're faced by somebody who's head to toe in their PPE with gloves and a face mask. Then, as you described, there's those ongoing impacts from the blood test itself. And of course, the patient has to travel home as well.
Dr. Chantal Rezan there. And blood tests are, of course, a really interesting one, because rather than choosing to do less testing for environmental reasons, doctors have been forced to do less due to a shortage of vials. However, it has made Dr. Navjoyt Lada, a GP and UK research editor at the British Medical Journal, rethink how often she tests. Hi, Navjoyt.
Hi, James. It's nice to be back.
Tell me about the blood tube shortage, because I remember seeing it in the news. What was there a shortage of, and is there still a shortage now?
In August, the main manufacturer for blood test tubes that we use in the NHS, they informed NHS England and NHS Improvement that they had a global shortage of the bottles they make. We had this letter that was circulated to GPs, to hospitals, to CCGs, basically alerting everyone, saying that we could only do urgent tests now. And things are returning to normal, although there is still a bit of constraint on the supply.
It was quite a big, bold announcement when it came. It was GPs, stop testing.
Exactly. I mean, it was kind of worrying. It was a bit of a shock, for sure.
So give me the really practical take on this. What could you still do and what couldn't you do the day that letter arrived?
Well, we were still able to do urgent tests that would help diagnose things like cancer or sepsis, or blood tests that were essential for monitoring a disease or drug, things like the monitoring tests for warfarin, where, you really want to make sure that the blood's not getting too thin, for example. The tests that we were no longer able to do were the more routine monitoring tests, say the sort of annual checkups you might do for someone with a thyroid problem or a high blood pressure to see how they're faring more generally, or the tests that you might do to help make a diagnosis in someone with specific symptoms, but where you didn't think it was a clinically urgent problem and we were just asking them to wait a little bit longer.
And was everyone quite chilled about this, the patients coming in? Or because I can imagine it would lead to some anxiety if you're closely monitoring a condition or you've got something where you don't know what's wrong, but now you can't get a test.
People varied in their response, but I would say in general, coming on the back of, a very difficult time during the pandemic, this can feel quite frustrating.
And obviously, Navjoy, you would have been used to being able to almost test at will, test whoever you thought needed it. But has the shortage made you rethink how many of those tests were appropriate and whether you should be doing as many in the future?
Yeah, I mean, I would say that overall the shortage was clearly a bad thing. We weren't able to request tests for people where we normally would have felt there was a clinical need for doing so. But yeah, as you say, it did give me the opportunity to reflect on actually before the shortage, how efficient were we being with the tests that were happening? And to what extent were things like the frequency of monitoring tests being driven by data and evidence versus just what we normally do? I don't know, the more I thought about it, the more I felt that there probably is a subset of our usual testing that could be considered as over-testing.
Go on, give me an example.
I mean, there are a few examples, but one that's close to home is I have a relative who has a monthly blood test because they take a medication that could potentially cause damage to the liver. So they're advised to have a liver function test every month. But as far as I know, there's not much data to say that that monthly test leads to better outcomes compared to a test every 6 weeks, or every 2 months, or maybe even a longer interval than that. And also, often because that test is happening anyway, other tests get added in. They get done because they might be useful as an overall, marker of health.
And then, Navjoy, there are the really common things as well, aren't there? Things like cholesterol levels or blood sugar levels that you just test people for quite a lot.
Yeah, well, I'm really glad you bring those up because those are tests that happen really frequently. And with cholesterol, I think that is one that can happen more than it needs to. So if you have someone who maybe initially had a high cholesterol and they've been on a statin and their cholesterol level has come down within a normal range and the dose of the statin that they're on has stayed the same, there's really no need to test that very frequently. But, occasionally I do see people having their cholesterol level checked 3 months, 6 months, when, a year or longer would be fine for that. So it's those kind of things as well, where there is maybe a margin to get more efficient.
And can you be more efficient when it comes to patients that you're seeing for the first time? Say if I came in and I was suffering from severe levels of tiredness and, that could be down to a whole host of conditions. Is there a better way of getting to the root cause of that?
If I see a patient who's come in with tiredness, which is a pretty common symptom that we see, most of the useful information I get will be from finding out from the patient more about what's been going on and from doing an examination. And from there, that might point to a specific test that I want to do. So say, for example, it's a woman, she's been having really heavy periods. I would think, okay, I should check for anemia as a potential cause. But then if I'm doing that test, should I also check for a low thyroid? Because that can also cause fatigue. But, what if the story and examination doesn't fit with an underactive thyroid? Maybe I should do it anyway so it doesn't get missed. The fact that I'm doing one test can sometimes mean that other things get thrown in. And I think it makes sense to have a way where you can add things in later once you've got one set of information back.
So Navjoy, you mentioned a lot of the blood tests that are done are kind of like habit. That's how often we do them rather than being rooted in evidence. So do you think there's going to be a lasting change because of this?
Yeah, I mean, these things are sort of classically quite hard to implement and sort of change at scale. And we've had some recent guidance that has gone out to clinicians and people requesting tests about optimizing blood tests, because I think this is something that does happen in practice, that maybe we're doing more than we need to, or we're not doing them as efficiently as we could be doing. But I suspect it will take more than just a document. You know, there are things like addressing the systems that we use. So, for example, when I'm requesting a blood test, a prompt might come up to remind me that, you know, these are the indications for doing the test, or this is the suggested monitoring frequency for this test. Things like that can just help these things kind of bed in a bit better. The other thing that I think we're being encouraged to do now as well is to do add-on testing. So if you had a blood test that was taken a couple of days ago, but it comes to light that you need another test, the lab might be able to add that on to the previous sample for you. So rather than having to do another draw, which is obviously inconvenient for the patient as well, you might be able to add it on. So that's another thing that is being looked at.
What's the driving force behind all of this? Because obviously we're just talking about it because there was a shortage, but it seems like there's bigger thoughts afoot here. Is it about saving the planet? Is it about saving money within the NHS?
I would say it's beneficial for patients first and foremost. And I would really encourage any listeners to feel able to ask questions about your blood tests, to know what tests am I having, what would it show, and what would happen if we didn't do it. Because there can be this mindset, it can't do any harm, but actually there is harm that can come from over-testing. We're all aware now of the false positives that can occur with any tests, which then can trigger a cascade of follow-up investigations, meaning potentially a raft of more unnecessary tests and anxiety for patients. You know, that creates workload for clinicians, it creates a cost for the health service, and definitely there's clearly a sustainability benefit here too.
Navjoy, thank you so much for coming on.
Thanks so much for having me, James.
I think there are going to be lots of questions for the whole of the health service to answer in the months and years to come about how it goes green and how to do that whilst also protecting patients in that process. We're definitely going to be covering this again in future episodes of Inside Health. But for this one, I wanted to give a final thought to face mask designer Alexis Percival.
People innately hate waste, and it's been exemplified by this pandemic with the sheer quantities of waste. And as a project, this has sparked people's imagination about what else can we do. So 63 trusts that we had in our trial across the UK, they've gone on and looked at their gowns, their aprons, their theatre caps, their scrubs, their medical instruments. They're looking at the whole of the NHS, and it's pushed the agenda. And so I've been sat on the bus by myself, and suddenly there's a party on the bus, and literally we are driving towards carbon reduction. It's fantastic to have so many people on board.
Are you the NHS Greta?
I would love to be. That would be a fantastic accolade.
Alexis, thank you so much for coming on.
Thank you.
Alexis Percival there. That's it for this episode of Inside Health from me, James Gallagher, producer Beth Eastwood, and studio manager John Boland. Next time, we're looking at people reversing their type 2 diabetes and pre-diabetes. If you have any questions, then tweet me at James T. Gallagher, or you can email insidehealth@bbc.co.uk. See you then.